Welcome to AETCM, the Emergency Medicine channel. Today we are discussing about an MBBS case, that is valvular heart disease. We'll see the details of the case. Dr. Gobika will be giving the details of the case. Can we start?
Yes.
Please start.
So I am presenting a case of a 57-year-old male, Venugopal. He is an excise officer. Came with complaints of swelling of both legs, breathlessness and cough since 8 months. So history of presenting illness. Patient was apparently asymptomatic 8 months back when he presented with swelling of both legs. It was sudden in onset, gradually progressed and first started on the foot.
Can you tell the causes of swelling in the legs?
Any trauma,
Okay.
then cardiac failure,
Okay.
CLD.
So most important cause is fluid overload.
Fluid
It can be
overload.
cardiac failure, liver failure, kidney failure, or any local trauma. All these things can produce bilateral lower limb swelling. Please continue.
It first started on the foot, then progressed till the scrotum within 8 months of duration. There is no aggravating or relieving factors. He also had breathlessness of 8 months duration, which was sudden in onset, gradually progressive. He couldn't walk fast continuously. Also, he couldn't walk up in a small height.
Can you tell the causes of acute breathlessness?
So it can be due to COPD,
Okay, COPD with acute exercise.
exacerbation. It can be cardiac
Cardiac
or
is the most important cause. Sudden onset of breathlessness. Cardiac is the most important. Then asthma, COPD, pulmonary embolism, pneumothorax, all these things. Please continue.
It got aggravated on lying down and while sleeping at night, and relieved on proper position, that is sitting
What is the
position.
difference between orthopnea and PND?
orthopnea means it's the breathlessness will increase when
On
you're lying
lying
down, and
PND
is
During-
we wake up suddenly from sleep.
So night, any
Due
time
to
he is
breathlessness.
getting breathlessness is paroxysmal
Paroxysmal nocturnal
nocturnal
dyspnea.
dyspnea. Orthopnea means immediately after
After.
lying down, patient is getting breathlessness. So that depends on the grade of the cardiac disease. Somebody is having minimal disease, he will have PND. Somebody is having maximum disease, he will have orthopnea. Please continue.
He also had cough, which was sudden in onset, non-productive in nature. It existed only for a short duration of period, and there is diurnal and postural variation. It got aggravated by sleeping at night and relieved on lying on left or right lateral position. He had one episode of hematemesis yesterday. It contains only 2 to 3 drops of blood after coughing, which was scanty in amount.
Which
So-
are the cardiac diseases which produces hemoptysis? This is hematemesis or hemoptysis? He had vomiting of blood or coughing out?
Hematemesis,
Hematemesis, vomiting of blood.
vomiting of
Okay.
blood.
What are the cardiac diseases which produces hemoptysis? That means while coughing you get blood in that. You know any cardiac disease? Mitral stenosis is the one of the common condition. You get blood in the cough, sputum. And pulmonary edema also sometimes you can get. Okay, please continue.
There is no abnormal taste or odor noted. And coming to the negative history, there is no fever, chills, rigor, syncope, headache. There is no abdominal pain, no palpitation, no chest pain, no sweating, no nausea or vomiting or sore throat.
So if you summarize the history, what is the problem of this patient?
It could be an cardiac failure.
Okay. Somebody is coming with acute recent
It's
onset
a
of
breathlessness and
Most
swelling.
important cause is cardiac
Cardiac
failure.
failure.
Other causes for similar presentation.
Ischemic.
Okay, ischemic heart disease is one important
among
cause. Then valvular heart disease.
disease.
Valvular heart disease normally is present with the younger age group, but somebody can present at this age also. Then anemia is one of the most important thing. It can produce its own symptoms. It can aggravate the problems like valve disease or heart disease. Okay, and other conditions like asthma, COPD and all. But this patient never had that history, so we have to think about a cardiac disease, possibly cardiac disease.
Coming to the past history, he had 6 hospital visits for the same complaints and 5 days of hospital admission. He had history of jaundice 20 years back, and he had undergone blood transfusion in the last year. He was diagnosed with a fatty liver 1 year back.
Why he had blood transfusion? That is very important.
His HB was low. As
Some elderly individual coming with low HB, what are the common reasons?
Blood loss.
blood loss.
Blood loss from GI tract. There you have to think about a malignancy. If he is not an alcoholic, think about malignancy. If he is alcoholic, it may be chronic liver disease. Okay.
There is no history of diabetes, hypertension, asthma, allergy, TB or any accidents. Personal history, he is having decreased sleep and appetite. His diet is mixed diet, normal bowel and bladder habits. And he is habituated to alcohol and he stopped 20 years back. He used since for 8 years.
Okay.
Family history, his mother
So
is
he has
hypertensive.
stopped alcohol, but he was taking alcohol.
He was taking alcohol.
So can it produce a liver disease?
Yes, sure.
Somebody is taking alcohol for a
More
long
than-
time. Even if he stopped, now he can have the complaints of alcoholic liver disease.
Family history, his mother is hypertensive and father expired due to cardiac arrest.
So he has got a positive cardiac history.
On examination, the patient is conscious, cooperative, well oriented to time, place and person. Height is about 165 centimeter, weight is 70 kilogram and the BMI is 25.7 kg per meter square. On general examination, pallor was present, icterus was present and bilateral pitting pedal edema was
How
present.
anemia adversely affect heart disease? Or what are the complications of anemia in heart disease? Anemia can increase the cardiac symptoms. That is very important. Okay.
Increase overload.
Increase overload, fluid overload, heart has to pump more metabolism. So heart disease can be aggravated by anemia. If any patient who is having heart disease, if you correct the anemia, patient can improve very easily.
There is no cyanosis, clubbing or lymphadenopathy. Vital signs, pulse rate is about 121 beats per minute. It's a low volume pulse, irregularly irregular and
Irregularly irregular heartbeat. What do you understand? What is the most important diagnosis of irregularly?
atrial
Atrial
fibrillation.
fibrillation. That is the most important problem. Atrial fibrillation means atrium is contracting very fast, but ventricle is not contracting that much, but still rate is very high. It is very irregular. Okay, what is the problem? Because of atrial fibrillation? Pumping can reduce. You told low volume pulse. Pumping can reduce and there will be stasis of blood in the atrium. So the patient can have thrombosis formation, embolic formation, all these things. Okay.
Condition of vessel wall is normal, no radial or radiofemoral delay, all peripheral pulses are palpable. And BP is 100/60 millimeter mercury taken from the right arm in supine position.
How
with
many
a normal-
readings you have to take in atrial fibrillation?
3 readings. you
Minimum
have
3
to
readings
take.
should be taken because the varying pulse pressure. So we have to take at least 3-4 readings and take an average. So that is very important.
The respiratory rate is 22 breaths per minute. It's abdominothoracic and the temperature is 96 degree Fahrenheit. Head to foot examination. On examination of the scalp, there is no alopecia. Hairline is supposed to be normal. Eyes, pallor and icterus was present. Nose, there is no deviation of the nasal septum, no flaring of the ala nasae. Lips appears to be normal. Mouth, there is good oral hygiene. Mouth, tongue, teeth, gums, palate appears to be normal. Ears are not ears. There is no specific abnormality. Neck, there is raised JVP seen and the distended neck veins are present.
What is the importance of JVP in the case of heart disease? JVP can be elevated in many conditions. But in heart disease, if JVP is elevated, means in simple terms, it is due to what? It is because of the cardiac failure. Whether it is right heart failure or left heart failure, ultimately pressure will be raised on the right heart and the JVP can be elevated. So in emergency room, if a patient is having elevated JVP, that means he is fluid overloaded. It can be due to cardiac failure, it can be due to liver failure, it can be due to anemia. Whatever it is, elevated JVP indicates there is failure and fluid overload.
Upper limb, there is IV cannula on the left forearm, hyperpigmentation seen in the right forearm and there is dry skin over both upper limbs. And also tremors were present. There is no clubbing. Chest appears to be normal and
Somebody is having, just for academic purpose, somebody is having tremors, atrial fibrillation, weight loss. What is cardiac failure? What is the first thing will come to your mind?
Hypothyroidism.
Hyperthyroidism. That is the most important differential diagnosis. Please continue.
and on examination of the lower limb, there is bilateral pitting pedal edema present and hyperpigmentation over the both legs. And on examination, systemic examination, First, we'll examine CVS.
Okay.
On inspection, shape of the chest is normal and the spine appears to be normal. No epigastric or suprasternal pulsations is seen. Apical impulse on examination, on inspection not seen, and the shape of the precordium appears to be normal. There is no precordial bulge.
Okay.
No visible pulsations or dilated veins. Palpation, there is no local rise in temperature or tenderness. Apex beat felt at the 6th left intercostal space.
What is the normal position of apical?
5th left
So
intercostal
slightly
space.
pushed out and down.
La-
That means what?
Megal.
It's a
Cardiomegaly.
Heart is enlarged, especially left ventricle. That directly indicates a cardiac failure case. Okay.
And 3 centimeter lateral to the mid-clavicular line. And the left parasternal he was not felt, and that there is no epigastric and supraclavicular pulsations felt. No thrill or tracheal tag or other pulsations.
Okay.
On percussion, cardiac borders were percussed. Right cardiac border corresponds to the right sternal border, and the left cardiac border corresponds to the apex. Left second intercostal space found to be resonant.
Okay. Most important part of this percussion is if the left second intercostal space is dull, you have to suspect pulmonary hypertension. Otherwise, percussion has got no value in a clinical cardiology. But second space percussion is very, very important.
On auscultation, on first auscultating the mitral area, S1 heard, and which is loud. There is a mid-diastolic murmur heard.
Okay. Can you tell how S1 is produced in our heart? S1 is produced due to mitral valve closure. Okay. So S1 loud means what? Loud S1 means what? It is a forceful closure of the mitral valve. You have to understand mitral valve is closed here very tightly and it opens with a pressure. It opens with a sound, that is opening snap. Then it closes with a sound, that is first start sound. So both are loud. Opening and closing is loud. That is because the valve is very tight. Both produces a sound. Opening snap, closing snap is first start sound. So loud first start sound for an MBBS student indicates what is the diagnosis for a loud first start sound. A loud first start sound always indicates mitral stenosis. Only one diagnosis for an MBBS student. It can be due to fever, it can be due to anemia. But a normal MBBS student, a loud first start sound in a cardiac case is mitral stenosis. Okay.
On auscultating tricuspid area, S1 is heard, which is loud, and there is also mid-diastolic murmur heard.
What is this? Can you describe the mid-diastolic murmur? Normally, what happens? It occurs in the diastole. There is a mid-diastolic murmur. Then you get a pre-systolic accentuation. What is this mid-diastolic murmur and pre-systolic accentuation? Mid-diastolic murmur means it flow in the mitral valve from the atrium to ventricle. There is a normal flow. At the end of the diastole, atrium will contract. That produces a pre-systolic accentuation. So in atrial fibrillation, what will happen to this pre-systolic accentuation? It will be absent because there is no contraction. Atrium is not contracting. It is fibrillating. So it is very, very simple. Blood flows from the atrium to ventricle. That produces a mid-diastolic murmur. But there is no atrial contraction in atrial fibrillation. So no pre-systolic accentuation. So you should remember that loud first start sound normally indicates mitral stenosis. It has got a mid-diastolic murmur. There is a flow from the atrium to ventricle. And final part is pre-systolic accentuation. That will be present only if there is normal heart rate. In atrial fibrillation, it will be absent. Okay. Can you tell conditions where first start sound is muffled? Muffled first start sound in mitral stenosis. It is calcification. Somebody asks you the question, tell the causes for absent first start sound in mitral stenosis. Most important cause is mitral valve calcification or associated MR, mitral regurgitation. That also reduces the first start sound. So here you get a loud first start sound. That means there is significant mitral stenosis. You are getting a mid-diastolic murmur, but you are not getting pre-systolic accentuation. So that all tells you that mitral stenosis is there, cardiac failure is there, but there is atrial fibrillation. Okay.
In aortic area, S1 heard and is normal, and S2
You are
is
told
also
that mitral area there is a murmur, tricuspid area there is a murmur. How do you differentiate these two? So if somebody asks you that whether it is a tricuspid murmur or mitral murmur, how do you answer?
deep inspiration
Increases the sounds of the right side. So ask the patient to take a deep inspiration. If it is a left-sided sound, it will reduce. If it is a right-sided sound, it
It will
increases.
increases.
Okay, or lift the legs so that more blood to right ventricle, right atrium, so the sound increases on the right side. That is called as decarvallar sign. Please continue.
And in pulmonary area, S1 and S2 are heard and are normal.
Okay. So what is the final diagnosis of this patient? Any
If
other
it is a-
systems are involved?
there is no.
No, but normally you have to check the pulmonary area because the patient is having cardiac failure. You have to look for bilateral basal crux, that is cardiac failure, pulmonary edema feature. Then neurological features, any altered behavior, stroke-like features, all these things we have to rule out. Liver we have to check because there is a cardiac failure, hepatomegaly can be there. So you have to check all these things, but here nothing is there. So what is the final diagnosis?
It might be a valvular heart disease with mitral stenosis.
Mitral stenosis,
Then heart failure.
atrial fibrillation.
Atrial fibrillation.
But there is a precipitating problem here. What is the precipitating problem? He has got anemia. So pallor is there, hemoptysis is there. So he had past history of anemia. That is the precipitating event in this patient. So there is a patient who is having cardiac failure. You found out the reason is due to mitral stenosis and atrial fibrillation, and anemia is the precipitating feature for this patient. Okay, how do you manage this patient, or what investigation you take normally?
We will send the ECG.
ECG is very important because there is a atrial fibrillation. You want to know what is the rate, and if the rate is very high, we have to control the rate. Okay, if there is a fibrillation, then we have to control the basic disease. What is the next investigation? Echo. Before that, we have to take an X-ray. You can rule out pulmonary edema. You can see the mitral stenosis changes. That is, left atrial enlargement can be ruled out. ECG. One more thing is that left atrial enlargement can be. What is the clinical ECG finding of left atrial enlargement?
No.
P mitral, notch in the P wave. Okay. Then echo should be done. Okay. And how do you treat this patient? This patient has got basically breathlessness because of the valvular heart disease. Fluid overload. What is the treatment? You have to give a diuretic. So you remove some amount of fluid, reduce the salt intake, reduce the water intake. You can basically treat the patient. But afterwards what you do, you find out a mitral stenosis in any patient without calcification, without regurgitation. What is the treatment? You dilate the valve. Okay. Valve should be dilated. That stenosed valve should be dilated. If there is a regurgitation or calcification, you have to replace the valve. Okay. So here basically the patient has come with breathlessness because of cardiac failure. That is aggravated by atrial fibrillation and anemia. So here we have to correct the anemia part also. We have to find out what is the reason for anemia. Sometimes it may be due to liver failure. Okay. So we have discussed the case. Thank you.